Welcome to Unrestrained, the podcast series from CPI. Here you can enjoy conversations where professionals on all sides of crisis and behavior management relax and open up about themselves, their workplace, and their clients. You'll get the latest tips and trends from the best in the business, so tune in often to integrate their experiences with your own. Hello and welcome to Unrestrained, the CPI podcast series. This is your host, Terry Vittone. Today, I'm joined by Sara Holland. She's a nurse educator with Virginia Mason Memorial Hospital in Yakima, Washington. Hello and welcome, Sara.
Hi, Terry. Thanks for having me.
You're welcome. Thanks for being with us. Let me tell you a little bit about our guest. Sara Holland began her nursing career well before college, serving for 6 years as a certified nursing assistant in a locked dementia care unit. She completed an associate degree in nursing at the Yakima Valley Community College in 2002, and eventually Sara earned both her Bachelor of Science and Master of Science in Nursing degrees. She began her career at Virginia Mason as a safety coach in the hospital's acute inpatient psychiatric care unit, and she started the hospital's first shared governance council on psychiatry and was asked in 2007 to become a professional assault crisis trainer, PROACT, which she taught for 3 years. In 2009, Sara spent 2 months as a nurse manager of Two Rivers Landing, a children's inpatient psychiatric facility in Yakima, but she quickly returned to adult psychiatry and eventually began to feel restless in her role as a nurse. And that changed in 2015 when she became a certified CPI nonviolent crisis intervention trainer. And that summer, with the blessing of her nurse manager, Sara began training with 2 other coworkers in January of 2016. And today she facilitates CPI training across the Virginia Mason Memorial family of services. And in addition, Sara writes curriculum for psychiatric specific education and interdisciplinary plans of care, as well as acting as a point of care reference for all things psychiatric and restraint. Our interview today is going to focus on the impact of CPI training at the hospital and how it helps to manage challenging behavior in both patients and visitors, as well as the way CPI training is facilitated through both online and traditional classroom methods. All right, Sara, so then after all that, let's begin. Let's talk about why Virginia Mason Memorial selected CPI training. I know in our pre-interview we talked about what you described as a skyrocketing number of assaults that you had happening.
We did. We were experiencing a lot of assaults throughout the services, both on medical floors, not just what you would think would be, legitimate like psych or ER. We were seeing it on a lot of just medical, neurological floors. There were higher levels of patients with dementia, very acutely ill, drug-related, delirium, all those kinds of things that you would see on medical floors. And people were getting injured, both patients and staff. And we took a look at the programs available. PROACT was not something that we were going to go back to, and that is where CPI reared its head in our system. We looked at the CPI values and looked at our values and saw how closely they were aligning, and obviously, decided to go with your program.
I see. And what specifically in a value structure would you say was agreed between CPI and Virginia Mason Memorial?
So with CPI, we have our care, welfare, safety, and security. We actually had safety as a value until we felt that we had reached that. So I've been here for 11 years, and so when I first started, safety was one of our values. It has now been replaced with stewardship because we have accomplished safety. When we look at care, welfare, safety, security, we have Memorial's respect and accountability and teamwork and innovation and stewardship. And if you look at your definitions, they line up just amazingly. And when I teach, I actually bring that to the forefront for the people I'm teaching, because they want to know why are we doing this program? What does it mean to me? How does it fit with my daily work? And you can tell them, well, we want to teach you how to keep yourself safe and keep your patients safe, and how to talk to people and how to restrain if absolutely necessary. But it also goes in line with what our beliefs are and how we reach out to our community and how we treat others.
I see. Now, I know in what you, in our pre-interview also, you mentioned that you had trained PROACT for 3 years, but that you decided not to renew, I think, back in 2010. And so you had this gap between 2010 and 2015 where there wasn't when these assaults started to skyrocket. Can you kind of paint that picture for us there with what happened with PROACT and how you came around to training, verbal de-escalation training again?
Yes. So I was teaching PROACT. It was considered a psychiatric specific training per the WACs here in Washington. And so I was teaching it to our psychiatric staff, and then we did incorporate some of the emergency room people. But then we would have things happen, like with home health, somebody answered the door with a gun, and things for Children's Village. There was a couple outlying programs that needed some support, some help, and so I did that. Well, they decided not to renew my credentialing in 2009, and instead took portions of PROACT and had several, one of our security officers at the time and one of our ER directors at the time, they kind of broke it apart, and they just taught components of what they thought was important when they would do onboarding. And as you know, these programs, regardless of what it is, they grow. They are layered programs. You have to figure out things about yourself before you can figure out things about others, and then you move on. And so just to pull a chunk out wasn't effective, and it wasn't reaching everyone, and it wasn't, everyone is looking for that why. Why am I doing it this way? Why? And we were just seeing more injuries and more LNIs, and sorry, I don't have stats for LNI claims, but it was an ongoing problem. And when it came around that, hey, it's one of those things where it starts to kind of talk. You start hearing talk here and talk there, and it comes up in a meeting. Why don't we have anything for this? And then pretty soon it was like, oh, hey, here's this crisis prevention. I was doing some research, and I came across this, and it aligns, and would you be interested in getting involved again? And I was like, oh, yes, please pick me. So here we are.
I see. So what staff and departments did you train?
Currently with crisis prevention, we initially opened it up to the hospital, and it became very evident that this was going to go across Memorial Family Services. And one of the reasons that we chose to do that was because at any given time, people are in and out of the hospital, and there may be an issue where someone from the lab will have to step in and help someone from the emergency room in the waiting room, or you might get someone from one of the outlying clinics who's here for a training and comes across a situation where now they can step in and help out. We wanted everyone to have the same skills, to have the same opportunity to learn at the same level, because as you know, if you've got two people who don't have the same training and they try to help, somebody can get hurt. It gets actually worse than not having any training at all.
So you're finding that by having, like you said, across the family of services, that CPI training, that you can have somebody from different departments assisting in the same intervention with an understanding of the methodology that they're going to use.
Yeah, and a common language.
Right.
And what comes next, and who should be talking, and the whole situation, and how realistically at the core is the patient's safety, and how we're going to get them where they need to go.
Now, I think when you started in a pre-interview, you offered employees a selection of either the 1-day, 2-day, or the flex training option. And can you explain how that evolved and kind of what worked out to be the best solution for Virginia Mason?
Right. So initially we didn't have flex. Flex came later. We offered 1-day training for the people who did not have direct patient access. Then we offered the 2-day training for people who, in fact, did have frontline, access to the patients. So people like ER, psych, med floors, nursing staff, clinical, that kind of stuff. The flex training came later. When we were trying to limit the hours in which we were actually in training, and we actually had someone else go and certify to teach the flex. What we were noticing is during our conversations with people in class, and I'm a big proponent of bringing people into class, into a forum, not just online, because that's when you get to process information, and you get input from other people, and you build the team.
Right.
And you don't build a team on just online components. And so we started recognizing that the issues weren't just the patients, that people are saying, well, I've had, doctors, get confrontational and scream and yell at me. I've had people have followed me into the elevator. I had a nurse back me up against the wall. So it was workplace violence too. And it wasn't just about the patients anymore. And we realized that we were basically handicapping people who really needed to take this full class to keep themselves safe. On top of that, we were coming across some areas that, like nursing assistants who are on our front lines doing one-to-one care with aggressive patients or in restraints, they were being not allowed to take the full 2-day class because they couldn't be pulled away that long.
I see.
And we decided that we were going to take that away from. We were going to pull that option.
Mm-hmm.
Everybody was going to get the same training. Everybody was going to get an opportunity to have hands-on.
I see.
And it actually has gone pretty well, I have to say. Just because you're not sitting in front of a patient doesn't mean you might not come across a situation where there's an aggressive person.
I see. So do you see that it is blended learning pretty much the standard then, part online and part classroom for how you train CPI?
Right now, so what we're doing right now is they do a 3-hour, well, it's 2 to 3 hours, comparatively, whoever's working on it there.
Mm-hmm.
And they do the online portion, and then we pull them into class for an entire day. And we do refreshers throughout
Mm-hmm.
the entire morning, and then in the afternoon, everybody gets the same restraint and restraint training and holds and oh my gosh, I'm just drawing a blank right now. And disengagement.
So, but it's great. So they have a chance then so they don't have to make this, a 2-day commitment, but they get to go online and to internalize and to sort of take their own time and then to come into the classroom situation and share and kind of talk about what they've absorbed and get further instruction to kind of really drive home the training, if you will.
Yes, and it's been really nice because, people learn in different ways. And
Mm-hmm.
so you have someone who might just be a reader, and that's all they need, and it makes sense to them. But some people have a really hard time putting it, like visualizing what it would look like until they've actually come into class and they've practiced it. And so, as an educator, the more times you can have someone hear something, the more it's going to sink in.
Mm-hmm.
And especially if you can show them in real time, what does that look like? We do, a lot of the role playing, and we get people up, and I actually have them teach each other when we're doing our refreshers. So I break it down into components, and we focus on what I consider our biggest main areas, our crisis development model, and the alternatives to behaviors, and we have them teach the other class members. And so not only are they reading it, they're hearing it, they're teaching it.
So truly multimodal kind of approach. That's great. And talk about some of the ways so how many staff members at Virginia Mason have been trained in CPI, do you think so far?
Oh, do I think so far? So our class average is 22.
Okay.
And in the beginning, so the first year, we did 2 classes a month, so 2-day classes a month.
Mm-hmm.
And then as the time had gone by, we added 1-day classes and we added flex classes. And now we are back to 3 1-day classes a month. And so, my gosh, I'd say if I had to average, I'd say probably at least half of our Memorial Family Services in 2 years have gone through that.
That's okay. So you're about 50% trained then.
And we're adding new people every, we're adding new staff members
Mm-hmm.
all the time. So
Right. All right. Is your goal 100%?
It would be 100%, which is always going to be an ongoing turnover.
Could you talk about, Sara, some of the ways CPI training has helped yourself to better manage patient and visitor behavior, and how that relates to your customer service model? We talked about that in our pre-interview.
Oh, yeah. Yes. So the really awesome part is that moment when you see someone have this light bulb and their eyes get big and they go, oh, I didn't think of it that way. Or I've been doing it wrong, or I never thought about that. I'll give you a couple of examples. We have a gal who is one of those bubbly people who is just happy all the time. And she did registration for ER. And so she would go into the emergency room and, hi, this is, my name is so-and-so, and I'm here to do your paperwork. And she's just a happy person. Through this training, she realized that she needs to check her tone and her volume and kind of bring it down a notch, because not everybody in crisis can tolerate that personality in order to not create the environment which could possibly engage hostility. She has a moment of, okay, walking into a room, bring her voice down, bring her tone down, slow her words down, so that she can better interact with the crisis, because no one comes to ER when they're having fun and not having issues. So she was able to check that about herself. There was another situation with one of the night shift psychiatric nurses, when we talked about re-engaging patients after crisis, and how I always teach everyone, we are the professional, we are responsible for their care, welfare, safety, and security. It is our job to re-engage with the client, the patient who has been in crisis. And he just said, oh my gosh, all this time I just wait for them to come up to me. And it's like, oh yeah, that doesn't work so well.
Right.
And so that was an aha moment for him. We had another psych nurse who was like, I didn't realize so much about myself and how my attitude contributed to outbursts in patients, to aggressiveness, to escalation. And so when they recognize that situation,
The integrated experience, essentially.
Yes, exactly. A lot of people talk about how recognizing the CPI crisis development model and the verbal escalation continuum, and how I take that and I pull it apart and I say, this is not the time for a code gray. What is the time for a code gray? That's our emergency response, where everybody comes running. A person is screaming and yelling at the desk. Is that dangerous? What's the level of dangerousness here? How do we respond? And so a lot of times you get injuries from code grays called inappropriately, and little old people getting tackled because they won't stay in their bed. And that's not appropriate. Teaching people this skill of recognizing what is dangerous or what is just scaring you, and then looking at our matrix and going, oh, this is this behavior, but it doesn't mean I have to react like this, because it might not turn out like it happened last.
Right.
And really weighing those risks.
It's great to hear that you're using that decision-making matrix in such a hands-on or sort of practical way, like really use this model to contrast to what you see happening in front of you. I also think it's really interesting that usually when we talk about paraverbals, about tone and volume, we're talking about not mirroring back the frustration and this sort of escalation and tension that happens when people start to get heated in conversation. It's really interesting that you had to train that nurse who was so bubbly to instead take a more sober sort of paraverbal tone with people, so that her exuberance didn't inflame the situation. I've really never heard of that before, but it makes total sense now that you bring it up.
Yeah, it's a reality check for a lot of people when they go, oh, my attitude is going to affect what's going on in front of me, how I'm behaving. I see people get into power struggles all the time with patients, and no, you're going to talk to me. I'm your nurse. This is how it's going to work. It's like, why are we fighting this uphill battle? Find some common ground here. Let's see what the need is and how we can facilitate that. Because at the end of the day, we're here to serve our customers, whether that's each other or the patients that come in, or the family members of the patients, or the locums that come. It's customer service.
Right. Excellent. And Sara, could you share a story about how CPI training helped you successfully de-escalate challenging behavior? I know that we had talked previously about a patient who was having some issues with her radio.
Right. So I had spent 10 and a half years on psychiatry, and I've trained a lot of people, and we've always have a lot of movement there as far as employees. And as many different employees as we have the same number of repeat psychiatric patients. And so you build rapport and relationships with patients. And one of the days that I was working, I had a gal who was actually not my patient, but I had worked with her many times before, and she always kind of ran that line right around very aggressive and angry and irritable. She was usually coming down off of something that she had ingested or smoked or something. And,
I see.
came back from lunch one day, and there she is at the front desk, screaming, cussing, yelling, demanding to see me. And I was not her nurse, but, as we know, sometimes the patient picks you. It's not about who's assigned, but who might have the best rapport with the patient. And so I asked her to meet me in her room to get her away from the audience and away from the front desk because she's screaming and yelling. And I said, I'm going to check in, clock in, I'll meet you down there. And she knew because I was consistent with what I would tell her that she could trust that from me. And I went down and I got her version of things, which is really important because we don't always know how the client in crisis sees the situation. And a lot of misconceptions can be cured if you just stop and listen to the patient for a second. So
Excellent.
I went down there. I got her version of things. She was feeling very powerless, very as if like there was nothing about her environment she could control. She just wanted to listen to some music. We'd had issues in the past where things had been thrown. The music she wanted to listen to wasn't appropriate. And so I got her version. I had to come back out, and I had to treatment plan with her staff member, the doctor, say, this is what we've come up with. She's willing to agree to these terms.
So you set limits for her.
Yep, absolutely. Is there any reason we can't, see if this will work? And we actually adjusted her treatment plan to allow her, some time to listen to the radio outside by herself, away from other people, because her music was not the general public's desired listening tunes.
Fair enough.
Yeah, and she was able to follow those limits and respect them, and as they were time sensitive, and not aggress, not become escalated, and not be assaulted, which in the past wasn't always something we were able to manage.
Well, it's a striking example of how this de-escalation model, first of all, you really listened to her, then you set effective limits. It not only did it de-escalate the situation that day, but it really affected the culture and the approach to the patient in a more holistic and ongoing sense. That's powerful.
Yeah, it was. And it's always nice when you get to the end of a situation and no one got hurt.
Mm-hmm. Do you guys put special emphasis on debriefing after every incident?
We do. So in the past, there was this real push to, okay, let's get together and what went wrong? How can we fix it?
Mm-hmm.
But we've changed the focus a bit to what went really well and what can we improve on. So we're trying to spin our positives versus focus on, what failed, or, how we do things. And I'm actually going to be heading here soon a collaboration effort between security and psychiatry, using the CPI model and our customer service, and really focusing on what our goals are and how to best facilitate safe interactions between the two departments when it comes to patient advocacy and patient crisis. So I'm very excited about that. It's in its baby stages, but I was talking with my manager this morning, and she authorized it, so yay.
You mentioned Code Gray is your code for emergency response. Do you have any stats about Code Grays and restraint reduction since CPI training was onboarded?
I actually do.
Uh-huh.
I do. So we started, I got certified in 2015, so our first full year was 2016, and then ongoing.
Mm-hmm.
What I've done is we had stats for all of 2016, but I stopped it as of the end of August because I wanted to make sure that they were even. So in comparison with 2016 through August, we had 50 Code Gray incidents. This year, from January to August of 2017, we've had 20.
Wow.
So we've definitely decreased our Code Gray calls overhead. Now, I would like to think, because I haven't been able to go back and say, well, what are some instances that you felt like you normally would have called code gray, but you didn't?
Mm-hmm.
I would love to know what the situation is there. But I had one of my guys run some reports for me regarding restraint application. And in 2016, we had 28 behavioral restraints.
Mm-hmm.
And in 2017, we've had only 19
Wow.
thus far. So then look at, for a second, med-surg restraint, because I was able to split behavioral versus med-surg. And this is what got really interesting to me. So in 2016, we had 1,358 med-surg restraints. In 2017, thus far, we've had 551.
Wow, that's dramatic.
And so the people that are getting put in med-surg restraints are so people on ventilators. That's kind of an ongoing thing that you do. So I was not able to pull that out, but we have things like dementia, issues with delirium, alcohol withdrawal, high ammonia levels, things that would cause confusion, disorientation in patients.
Mm-hmm.
And so they would be in med-surg restraints. Otherwise, the behavioral ones would kick in if it was behavioral related.
Mm-hmm.
So to me, people are very obviously, managing behaviors, managing interactions better. And this is happening on med-surg floors.
People are internalizing a hands-off approach then.
Mm-hmm.
Well, the stats certainly seem to bear that out. And you sense it. I can tell in the tone. I can sort of feel in the tone of your voice that you're sort of convicted that the reason that this is happening is because people are being trained in things like the crisis development model and how to utilize that rather than letting something escalate to the point of a restraint being needed to be used.
Right. Yes. Yep. Absolutely. Intervening early, recognizing triggers and symptoms, and if you have a dementia patient, to me, it's not rocket science, but don't stop to think. If you have a dementia patient that sundowns at 5 o'clock, let's get meds on board at 3:30. Avoid the whole issue. You know what I mean?
Mm-hmm.
How do you talk kindly? You're not arguing with people. We have something called EDIT, which is our customer service model here, and how to talk to people when you interact with them. And it's something I really pull into.
Would you repeat the name for me, Sarah? I didn't quite get it.
It's called ADIT.
Okay.
It's an acronym. It stands for, it's AIDET. It stands for Acknowledge, Introduce, Duration, Explanation, and Thank You. So you walk into a room, you acknowledge everyone who's in the room, if they have guests, if they have family there. You introduce yourself and your credentials. You let them know how long you're going to be involved in what's going on, and you explain the procedure or what you need to do. And then you thank them, and you ask them if there's anything else you can do for them. When I ask the people that are working, I say, okay, you're going to go in and do an assessment on somebody. Tell me what you do. Lucky, even not, half the time. So they're just blowing through the door, pulling back clothes, making adjustments, giving meds. There's never a conversation happening. There's not, this is what I'm doing. This is what you can expect. We live in a culture of go, 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 go. And it's our enemy. And I have to remind people that time is relevant. We have to slow it down to get it right. We have to, it's skewed when we're in crisis. And it works for staff, too. We're skewed with staff.
And that, when things start to become routine, you somehow feel that other people can intuitively know what you're doing when, in fact, you need to communicate it to them verbally because they can't read your mind. And I think I can see where that working through that acronym is just a way to remind yourself, this is a human being. They're not going to know, I know I've got a lot to do, but like you said, time is a relative thing. And, what's more important, just the perfunctory tasks that you need to perform in the room are actually making sure that the patient feels a sense of well-being. And it must improve accuracy, too, to have people actually deliberately think of those steps.
Yeah, and the other thing is that when we go into a patient's room, when we interact with them, and we don't tell them what's going on, their cognition, if you're in pain, if you're sedated, if you are delirious, you're not in contact with reality. Your cognition is lowered based on the level of crisis you're in. So it takes even longer to reach some people. how are you going to react if somebody comes in and yanks your covers off when you're like, delirious? I'd start swinging too.
Right.
So it's just, it's about respect and caring about how someone feels and how do we interact with them.
Excellent. Now, mentioning these statistical reductions in code grays and restraints, how would you say that the impression of the administration is of CPI training? Is it getting through the value of the program? Do you feel?
I do. I think that we have new leadership, not new to our hospital, but new as in they just stepped into these positions just a couple of years ago. When I look at, old people retiring, we've got newer ones in. And so it's kind of a fresh eyes on what's going on. And one thing, our nurse managers and CSO, I'm going to totally screw this up, she tells us that the injuries that staff are getting, it's no longer acceptable. So she kind of drew a line in the sand and she said, we're not going to allow this to happen. It's not okay. And so I take that and use it for my training. It's not okay to be hurt. When you are debriefing the patient, when you are going through re-engaging, it's not okay to say, it's okay if a patient comes up to apologize to you. It's okay. I'm all right. We're fine. It's not okay. Don't tell people it's okay.
Right.
And so our senior leadership is really backing people up on protecting yourself. And, this is a big thing. This is a big across the family services movement, and they supported it.
That's great. Well, Sara, to close today, I'm going to ask you something that we didn't talk about before, and that's I'm wondering what the biggest source of joy is for you in your work there at the hospital.
My biggest source of joy is educating people, is teaching people things they didn't know and then watching them use it successfully. I love to do that. I did that on psychiatry. I precept a lot of students. I teach all across, all disciplines. I'm the provider educator for the hospital. So I really enjoy helping people become successful in their environment.
Excellent. Well, I want to thank you, Sara. My guest today has been Sara Holland. She's a nurse educator with Virginia Mason Memorial Hospital in Yakima, Washington. Thank you so much.
You're very welcome, Terry. Thank you.
Thank you, and thank you all for listening. Thank you for joining us today on Unrestrained. Tune in again soon for another interview with an expert in behavior management. Until then, this is your host, Terry Vittone, hoping your intention is prevention.